Hello, everyone, and welcome to our second lecture on tobacco and nicotine. So we're going to continue to look at tobacco. We've already gone over the history last time, and we've talked about some of the effects of use in terms of the acute and chronic effects on the brain and on the body. This time we'll get to talk a little more about the social effects, and one of these is dependence. So in this lecture, we'll try to understand how society has reacted to tobacco and to tobacco use. Uh, Again, we already talked about some of this in the previous lecture with the history of tobacco. At first, especially the European powers, latched on to the idea that tobacco could be a powerful economic product, and it certainly was and continues to be. And now we'll talk more about current, or at least recent, um, changes in society due to tobacco. And part of that will be examining trends in tobacco use. Who uses tobacco? What form of tobacco do they use? And so on. And we'll also talk about nicotine dependence, which, of course, is something that occurs fairly readily after a repeated use of tobacco. So, how does dependence develop? Why is it developed so easily in the case of tobacco? And what can be used to address that dependence? Okay, but before we continue our discussion of tobacco, I want to talk about last week's discussion questions. So last week we were talking about alcohol. One of the questions is about liver transplants. So if someone is a chronic abuser of alcohol, um, should that be considered when placing them in terms of the list of priorities for transplants? So most people felt that yes, that alcoholics should be lower on the list. Of course, an important thing to ask is whether it matters if they're currently abusing alcohol. So if they've used alcohol 10 years ago, stopped, and now they have some cirrhosis to a degree that they need a transplant, are they still prioritized lower? Is it the fact that their current behavior it involves the abuse of alcohol, or is it abuse at any time? A lot of people favored uh, abstaining from alcohol before a transplant as a condition of getting the liver. And this is a common criterion that is implemented. So making sure that even if someone is on the list because they've used alcohol, making sure they're not continuing to do so is important. Also, several groups recommended behavioral approaches after the transplant to make sure the person stays off alcohol, to make sure they're not getting a new liver and then ruining that liver because livers are in short supply. They're a valuable resource. Is it fair to effectively throw away that liver by continuing to abuse alcohol? And so many groups favored behavioral therapy following a transplant. One important issue to consider, though, is that it's the categorization of dependent on alcohol or not is not black or white. It's not that simple. So is it simply this person is dependent on alcohol, they're by the bottom of the list? This person is not, they're prioritized normally. Um, Determining how dependent someone is on alcohol is a difficult problem in and of itself. The other discussion question was about criteria for intoxication. So especially when someone is driving. So if they're driving for alcohol, this is a fairly straightforward issue in our society. They are administered tests to determine their blood alcohol level. It's a scientific measurement. It's a physiological measurement. Um, but what about, especially when it comes to other drugs, that may not be feasible. It may be difficult to measure that substance in the blood. And so how do we deal with that issue? For things like marijuana, for example. Um, well, we can't measure the level of psychoactive drugs in the system on the spot. So do we hold the person pending a drug test? That carries with it a variety of legal issues. Um, or do we use a behavioral test? And so the thing about behavioral tests is that they're subjective. They depend on the perception of the tester. It's not something easily quantified, like blood alcohol content. Also, certain behavioral tests uh, the criterion may be triggered at a very low dosage. Somebody may have physiological symptoms of the drug, when in fact cognitively they're not impaired. And of course, the cognition is what we care about. We're trying to maximize the safety of our roads, for example. So if someone has dilated pupils, but behaviorally they're not cognitively impaired, they're still okay to drive. Is it okay to use pupil dilation as evidence of impairment? It's a hard question. So the discussion questions are very good. Keep up the good work. We will stick with those discussion groups for our week on tobacco, and I will shuffle them for next time. Okay, so getting back to tobacco, uh, this time we'll talk more about the social effects of tobacco. And of course, tobacco has had a history of opposition. When it was first brought to Europe, it was opposed by royal families, it was opposed by religious groups, um, but of course it was also supported by a lot of people. Some people thought it was this wonder drug, this medicine, and it does have some medical effects. It's an analgesic. It dulls pain. Um, it increases alertness. Uh, but a lot of groups were opposed to tobacco from the outset. Nevertheless, it became very popular, especially economically. But getting away from sort of older history, talking about regulations in the U.S., one of the, once research started coming out that tobacco was harmful, um, in the 70s, in the early 70s, uh, cigarette ads were pulled from radio and TV. You don't see cigarette ads anymore, when in the 60s you certainly did. You still see them in print ads, you still see them on billboards, but this was a way of addressing advertising and how products were advertised, especially to children, for example. And of course, regulations also come in uh, for things like public transit. So we know the effects of secondhand smoke. Once that started becoming apparent, you no longer have smoking flights, um, which many of you may never have experienced that, but um, you may have experienced not smoking flights, but airplanes that smelled like smoke because people were smoking on the plane. So that is a relatively new regulation. It came up in the early 90s. So buses, airplanes, smoking is banned because it's an enclosed space where you can't get away from the smoke. Also, public places. So again, in the interest of public health, diminishing people's exposure to secondhand smoke, especially in public. So this is not a private residence. And of course, things like bars and restaurants have started to follow suit on this front. One of the most noticeable has been the placement of warning labels on packs of cigarettes in particular. And so now there's a Surgeon General's warning that describes the effects of tobacco. One thing that's been discussed is the reduction of nicotine levels. And this is sort of an offshoot of earlier efforts by the tobacco industry to create a so-called safer cigarette. So trying to lower the levels of tar, which is that mixture of carcinogenic hydrocarbons. Um, and so you have introduced the introduction of things like filters on cigarettes. But also, the idea was that uh, nicotine levels could be reduced in cigarettes. It had actually been found, and this is the subject of a lawsuit, that the tobacco companies have been manipulating nicotine levels in an effort to make cigarettes more addictive. Um, so trying to address this issue of addiction, one thought was to reduce nicotine levels in cigarettes. And that would be great in terms of lowering the incidence of addiction, perhaps. But the downside is that what if people just compensate for the lower nicotine by smoking more cigarettes? So you would end up, A, the person would spend more, so it's an economic issue. B, they would end up with the same level of nicotine anyway. And C, they would end up with more of those other compounds. So they get the same level of nicotine in their system, they would have to take in more tar, more carbon monoxide, more of those other compounds we talked about last time. So that's the issue there, is whether it's just that the person would end up smoking more cigarettes to get the same level of nicotine. And of course, there have been lawsuits for manipulating nicotine levels. for suppressing research that highlights the negative health consequences, particularly cancer. And so society has responded to tobacco and to tobacco companies for unethical practices. So who smokes and how has that changed over time? So one thing we've seen is a change in the pattern of usage for tobacco, and particularly smokeless tobacco. So for example, you had snuff, which became in the 1700s, that is the 18th century. Of course, native groups either chewed tobacco leaves or smoked them, but snuff, that powdered form of tobacco, was a relatively recent invention, so that became popular, and that popularity has since declined. But you also had the rise of chewing tobacco starting in the late 1700s, and it became very popular in the 1800s. In fact, it was the most popular form of tobacco. Cigarettes didn't, as I mentioned last time, did not become popular until the early 20th century. Chewing tobacco was far more popular, and far more tobacco plantations were devoted to chewing tobacco as opposed to smoking tobacco in the 18th and 19th centuries. Chewing tobacco actually saw a resurgence in the 1970s and 1980s. And I saw this myself and many of my friends. Chewing tobacco was not the most attractive habit. Um, as we saw last time, chewing tobacco versus smoking tobacco have different health consequences. They also have different social effects in terms of how obtrusive the habit is. When someone else is smoking, they produce smoke, which is obnoxious. When someone else is chewing tobacco, they produce more saliva, and so they have to have some way to get rid of it usually. Anyway, because people started becoming aware of the increased risk of lung cancer from smoking, many started turning to chewing tobacco, which again has its own negative health consequences, but nevertheless, it became more popular in the 70s and 80s. And of course, smoking tobacco was the original form of use, um, but didn't really become popular until the 20th century. So last time I mentioned cigars, and cigars were the sort of transition from chewing to smoking, because you still have those tobacco leaves in your mouth, you're still chewing on them, but you also have the ability to smoke and inhale the cigar smoke. Um, but cigars eventually gave way to cigarettes, and cigarettes became very popular up through the 60s, up through the early 80s. But since then, anti-smoking efforts have really been pretty successful, not completely successful, but cigarette use has fallen. We can see this here in the graph on the right, and this is from your textbook. So what we see is not just a decline in the total sales of cigarettes, but also in the per capita usage of cigarettes. What we see here on the right half of that graph is that those lines match fairly well. The slopes, the levels, they seem to follow the same pattern over time. And what that tells us is that it's not that cigarette smokers are remaining constant in terms of their numbers and just smoking fewer cigarettes. It does actually tell us there are fewer cigarette smokers. And so, well, another thing to notice is that the bottom part of this graph, the bottommost level, is not zero. We're not that close to zero. It's still 1,000 cigarettes per capita per year. But we have significantly decreased cigarette usage and smoking since the 60s and even the 80s. However, there are other forms of tobacco that have become more popular. So, for example, hookahs, which are communal smoking devices. They're too cumbersome to carry around with you, but this is a way for a group of people to smoke tobacco, and they're usually flavored or scented. And so there's some evidence that in the early 2000s this has become more popular. It's not clear whether that trend still exists or how popular they ever were, but it's another form that, as usual, people, once one form of drug use becomes less popular or less acceptable, people will often seek out another way that doesn't seem as harmful. or doesn't seem as unacceptable socially. You also have the more recent appearance or popularity of e-cigarettes. And so these are devices that use heat to vaporize a nicotine solution. These are often also scented or flavored. They have the advantage of not having tar, not having a lot of those chemicals that are so harmful, but they do still contain nicotine, and nicotine itself does have negative health consequences. Okay, so that is sort of a short history of tobacco usage in recent history, and a coverage of the forms of tobacco that are used. But in terms of who's using tobacco, one thing, tobacco use is more common in men than women by a few percent, well, particularly for smoking. For chewing tobacco, it's far more common in men than women. One interesting correlate is education level. So college graduates and current college students are far less likely to smoke than individuals that never went to college or even don't intend to. It's not always um, post hoc. You can look at smoking behavior during high school or even middle school, and individuals that end up going to college tend not to have as high incidence of smoking. Of course, education levels also correlated with socioeconomic status. Um, so individuals that make less money actually tend to smoke more, which is unfortunate because cigarettes are quite expensive, especially with the taxes that are intended to reduce cigarette use. About 9% of high school seniors are current smokers. And that's down from 20 years ago, for example. So again, we see a trend away from smoking, but it's certainly not 0% yet. And overall, currently about 19% of the U.S. population engages in smoking. But again, this is down from more than twice that number in the 1960s. So cigarette smoking has gone down by about 50% since then. And then the 60s were a real peak in cigarette smoking. So we're sort of halfway there in a sense. Um, one interesting thing demographically is also the co-occurrence of tobacco use and mental illness. So for example, tobacco use and smoking in particular is correlated with depression, which is a psychological disorder we've already talked about in our unit on psychotherapeutic drugs. But people with depression are more likely to smoke, but we still have a question as to the causal relationship. Is it that depression made them start smoking? Is it that both smoking and depression have a common cause? We don't know. So one theory is that people with depression are actually self-medicating in a way, that the nicotine um, helps regulate their neurotransmitter levels. And this is something else we also see with schizophrenia. There's a very high incidence of smoking in people with schizophrenia. It's almost 90%, which as compared to the figure above, is a huge increase in the smoking rate. Now that's not thought to be a coincidence either. Um, and so it's thought perhaps that people with schizophrenia are self-medicating, that cigarettes, and nicotine in particular, are regulating their neurotransmitter levels. So they're smoking as a means of regulating their own nervous system. That's just one theory. There are others, of course, that perhaps schizophrenia causes cigarette smoking. Um, so we don't know exactly what that relationship is, but we do know there's a correlation. And this is not a correlation, but one thing that's been thought of is the treatment of Alzheimer's disease with nicotine. So again, the research isn't definitive, but it's possible that nicotine helps with memory. And of course, the major symptom of Alzheimer's disease is memory loss. So what if we apply nicotine as a medication for Alzheimer's disease? It's a possibility that's being looked into. So nicotine dependence is a common consequence of tobacco use. And it's thought this happens for a variety of reasons, one of which is the reinforcing effects of tobacco smoking through dopamine. So indirectly, nicotine increases dopamine levels in the brain, and dopamine, while we want to stay away from the idea that dopamine equals reward, that's a little simplistic, dopamine does seem to be involved in reward processing and learning behavior, um, and uh, and so dopamine is commonly correlated with how addictive a drug is. Drugs that affect the dopamine system, on average, have a higher incidence of dependence than drugs that don't. You also have a very quick onset of tolerance. Even after just a couple of cigarettes, somebody can be tolerant to nicotine. So last time I mentioned the incidence of those acute low-level symptoms of nicotine poisoning for first-time users of tobacco, but those go away pretty quickly. So tolerance is another risk factor for dependence. Smoking itself is also sort of a ritual. It is a stereotyped physical movement, and so those sorts of movements are easier to form habits around, especially when they occur as frequently as smoking does. So the effects of nicotine wear off after about 30 minutes, which means to maintain those nicotine levels, a smoker has to use tobacco every half hour or so. So just by sheer frequency of use, that is correlated with how easy it is to develop a habit. If you only do it once every couple of days, that's very different from a stereotyped movement, that is smoking, um, that occurs many times in a given day. And there are actually withdrawal symptoms for nicotine dependence. Um, they're fairly mild relative to other drugs. Someone who's going through it wouldn't tell you they're mild, but for example, you have irritability. You also tend to have a change in diet. So nicotine, there's evidence that it is an appetite suppressant. So it, in a sense, deadens the taste buds. It also changes um, the motility of the digestive system, and so it affects hunger. It suppresses hunger, and so as soon as you're off nicotine, now that hunger comes back, so it's no longer suppressing hunger and the desire for food, and so people who have quit smoking tend to change their diet and tend to overeat a little bit. Again, these symptoms are not severe, but they are noticeable. Okay, so suppose you become dependent. What are your options? So what you're really addicted to, of course, is nicotine, not the other substances. But it took a while for nicotine addiction to be recognized. For a long time, of course, we had this sort of moral model of drug use, that it was simply a matter of willpower. But now we know that there are biological foundations for dependence, for addiction. So that was a big step, saying that this is a biological process, not just a spiritual or a moral one. So there are behavioral approaches, there are training programs, there are things like group therapy to deal with nicotine dependence, but there are also pharmacological approaches. There are, for example, nicotine patches. So this is a sticker that I'm sure many of us have seen that goes on the skin, and it transmits nicotine across the skin. Nicotine is absorbed through the skin. And so this way, the person that has that nicotine in their system at a fairly constant level, and it alleviates the need to use tobacco. So again, this isn't directly addressing their nicotine dependence, but it does get them out of the habit of using tobacco. And also, you can more easily control the nicotine level. You can step down in terms of the dosage that you're using. E-cigarettes have also been used as a potential approach for nicotine dependence. And again, there's some controversy here because you still have that action of smoking. It's still a regular, frequent habit. And really all you've done is take away the other chemicals in the cigarette. So you've gotten rid of the tar. It's still a nicotine vapor. So you're not really treating dependence. The dependence is still there, not unlike treating heroin dependence with methadone, which we'll get to later. So the dependence is still present. What you're really doing is switching someone over to a less harmful version of the drug. And in this case, it's the same drug, it's still nicotine, but you're getting rid of those harmful other products. There are also drugs that one can take, things like Zyban, which is marketed as an antidepressant as Wellbutrin. So there are pills one can take that either directly or indirectly address nicotine dependence. And again, some of these mechanisms aren't entirely clear, but this antidepressant, this particular one, does seem to help as a smoking cessation aid. But of course, as many of us know, there's a high relapse rate for nicotine dependence. So even if someone quits, it's very easy for them to relapse and get back onto nicotine, start using tobacco again. And it's thought that the main reason for this is that there are so many potential cues that trigger desire for tobacco in an individual. It's not just physiological, that if someone smokes whenever they drink alcohol, that the appearance of an alcoholic beverage or the being in a bar, for example, can trigger these cravings for tobacco. Or if someone, because a smoker tends to smoke cigarettes so frequently, that an environment just outside the workplace, or someone smokes, people you smoke with, because it's such a frequent habit, and because it's more socially acceptable, you're more likely to run into these triggers, these cues, in everyday life. And it's thought that's one of the reasons that tobacco use has such a high relapse rate. But of course, getting free of dependence is possible. And so even if you relapse, it's always encouraged to try again. Sometimes it takes people quite a few times to finally break free of tobacco use, but it is possible. Okay, so that is it for our unit on tobacco. Next time, we will start discussing marijuana, which is obviously a popular drug. It's a famous one, and it's particularly important for us here in Colorado. So we'll look at the history of marijuana. We'll look at, as always, what it does to the brain and what marijuana does to a person's behavior. What are the effects, both acute and chronic, of marijuana use? And how has society responded to marijuana? And of course, this has varied greatly over history and even over geographic location. So we'll talk about all of that next time, and I will see you then.